Welcome to Alive and Well, your healthy living podcast for movement professionals and for the professionally curious. We have Dr. Stuart McGill with us today. He is out of Waterloo, Canada. Are you in Waterloo today?
No, I'm not. I retired 3 years ago from the university.
Okay.
So I retired to a town called Gravenhurst, about 3 hours north of the university. And I have a little clinic here.
Oh, fantastic. Fantastic. Dr. Stuart McGill's website is backfitpro.com if you want to go there while we're speaking today and check out a little bit more than we're talking about. He is Professor Emeritus from the University of Waterloo in Waterloo, Ontario, Canada, where he was a professor for 30 years. His advice is sought by governments, corporations, legal experts, medical groups, and elite athletes. He has over 240 peer-reviewed scientific journal papers, several textbooks, international awards, and to back up on the textbooks, we have Low Back Disorders behind us. We have The Back Mechanic and Ultimate Back Fitness and The Gift of Injury. Welcome, Dr. McGill.
Well, thank you very much, Karina. I'm really looking forward to this for several reasons, but those will become apparent as we go through this.
Great. And you are a doctor of kinesiology, correct?
Well, my PhD was in spine biomechanics in the Department of Kinesiology, actually, yes.
Okay. And then after graduating with a PhD, did you begin teaching directly, or what were you doing immediately after that?
I did become what was called a research assistant professor. And then within a year, I was an assistant professor and started with my laboratories and whatnot. So over the 30 some odd years, we had two laboratories. One was an in vitro laboratory where we took cadaveric spines and we created the injuries in them. So we got a one-to-one match between what very specific tissue damage emerged from a very specific loading scenario. And then what was the cascade? In other words, disc bulges, for example, quite often start with another insult farther upstream. For example, an overload of compression might crack an end plate at the micro level and then allow some of the collagen strands that form the annulus to delaminate a little bit. Anyway, we documented those cascades, and then we had the second lab, which was the in Vivo Lab, where we measured real people. And basically, we constructed their virtual spine from stacking their CTs or MR scans. We would have their spine in the computer, but it was very dynamic in that as the person moved, we would monitor their three-dimensional movement, and then with EMG, we would measure their muscles activating, and then we would activate their virtual muscles. As they moved passively, we would then assign stress-strain curves to the disc, the various ligaments, and that kind of thing. And then the third part of the whole scientific effort was I started a clinic just over 20 years ago. It was an experimental clinic, and I'm probably talking too much at this point.
No, not at all.
But it was very unique in that our first appointments were 2 hours long, and my traditionally trained colleagues would say, 2 hours for an appointment, what are you going to do? And but I said, I must do that because, first of all, we have to listen to the patient's story. Are the impediments that cause them to systematically fail in the previous 12 clinical experiences they had before they got here? We had to understand those. And then to listen to their pain patterns. We would then do provocative testing to provoke the pain, so we knew very precisely what caused their pain. Sometimes this was very mysterious to the patient. They said, well, we never really had an idea of what caused our pain, but we certainly do now. And then the next part of it was to come up with the antidote? Can we get them to move and do their tasks in a way that doesn't trigger the offensive trigger? And then build a program that fits their particular goals and injury history and age and all the rest of it. So that was what we did, and part and parcel of all of that, of course, you teach the graduate students that are putting the horsepower in the scientific operation, and I taught some undergraduate courses along the way as well. But that's it in a nutshell.
And so you're still doing something similar at your clinic there?
Well, patients fly in from around the world, and they get a very thorough assessment, and most of the time, a really thorough understanding of what their pain mechanism is, together with a strategy to deal with it. Now, I know you are a scoliosis expert. I do not call myself a scoliosis expert, although I have a few opinions and a little bit of experience with it. But I certainly wouldn't consider myself a frontline scoliosis. I'm aware of certainly what you do, and I'm sure we're going to have some discussions about this.
Yeah. Well, you'll be happy to know that you helped me on my own path tremendously before investigating the scoliosis specific route. So having back pain since the age of about 10 years old, so not my entire life, fortunately, it was always kind of a mystery to me what was going on and what was the proper care. And having had a professional dance career, and having had back pain take me out of that career, it was your books are infinitely interesting to me. And I do remember buying your books the first time, and one of the parts that intrigued me before, beginning from the beginning, was the discussion you have on silly stretches in the book, those stretches where you might hug your knees to your chest, or maybe hang out in child's pose for a bit. And can you explain to us why those stretches might feel good for a moment, but ultimately aren't the best choice?
Yes. Let me give a framework and a context to that. So I think the seminal issue here is, are we discussing a concept for a group of back pain people or for an individual? So when you write a book, by the way, when I wrote Back Mechanic, the original publishers said, you must have in the title, Fix Your Back in 5 Easy Steps. And I said, I'm not writing that because it's not true. There's no such thing as general back pain, just like there's no such thing as non-specific leg pain. It's all very specific, and people have to be subcategorized into categories that they will do well with a specific type of approach. But for the next group, that approach will be very inappropriate and will probably make them worse. So when you write a book, what I did with Back Mechanic was to guide the reader through a self-assessment of their pain to start to get some subcategorization. So it might be that bending backwards causes their pain. So let's take a typical pattern within the dance community, since that's your background. It's quite prevalent to have extensor-driven pain. So if that subgroup was identified that way, I could write a more definitive approach to say, here are some strategies to avoid extension, let your pain wind down, let the tissues that are causing the pain desensitize and adapt, and we'll go from there. So now I can answer your question about the silly stretches. I wrote Back Mechanic primarily for the readers between 20 and 55 years of age. The dominant pain mechanism for that demographic will be discogenic, so disc bulges and a little bit of loss of disc height and that kind of thing. Many of those people have been told pull your knees to your chest, stretch your hamstrings, and that kind of thing. Well, since they fell into a discogenic category, it's paradoxical. Pulling your knees to your chest fires off a stretch reflex. In most people, that gives a little bit of a neurological jolly, or really it's an analgesic for about 15 or 20 minutes. So they get the perception that what they just did was good. It was pain relieving. But the problem with it is the disc has now been further sensitized so that you now need to stretch again and again and again, and it's a never-ending battle. So I call them, just for that particular subcategory, rather silly. Now, we follow up with every patient that we see, Karina. We know exactly the score. Those who fall into that flexion-triggered discogenic category, when we advise them to stop flexion stretching and pulling their knees to their chest, they say, oh, well, I feel odd for 2 or 3 days because I'm used to feeding the stretch reflex. However, then my pain started to desensitize. So that's the story, because you write a book for a group. But now I have to play the other side of the coin and the argument, and that is every person that comes here gets a personal assessment, and we figure out with precision what their pain triggers are. And it may very well be, say we did have a person who came in with a cofactor of a structural deviation like spondylolisthesis, like scoliosis. Now, of course, I'm a big believer. I've measured the various Schroth techniques, Gabriella Schroth, for a scoliosis person. I may very well try and hold down a rib cage and stretch and open up the deficit side, and there is some efficacious data on that. But you will know with the person in front of you, if you follow up, have you helped them or not? So is the stretch silly for them? Absolutely not. So anyway, there's the broad context when you write a book versus you're dealing with a person who is sitting in front of you.
Yeah. Yeah, I understand what you're saying, really paying attention. And certainly when I started following your work and the DVDs that I got from you early on, it was very clear that that was what you were about. You were about, the case study of the person in front of you. And certainly that's very, very rewarding as someone who's also trying to help people.